Dr. Tufail Ahmed for that insightful presentation. Professor Dr. Javed Ahmed is unable to attend for some urgent visa issue. Therefore, now I am inviting Dr. Nitai Chaudhary, Associate Professor, Department of Nephrology, to speak on hypertension and kidney disease. Thank you.
Honorable today's chairperson sir and co-chairperson sir, distinguished guest, my respected other panel members, my senior and respected teachers, my senior colleagues and my junior colleagues, beloved intern doctors and my students and all other learned audience. Very good morning. I am Dr. Nitai Rai. Welcome you all to my presentation. I am very much privileged to be here to present my topics in front of this very learned audience. My today's topics is hypertension and kidney disease. Both these two terms are very important clinically, and these two are very closely interrelated and usually do affect multiple systems of our body, leading to various forms of comorbidities and mortalities. So, today's topics, hypertension and kidney disease, is going to be a very clinically important and interesting topics. So, I like to present my topics in brief. And the management of these two broad issues is very multidisciplinary and usually needs an integrated and multidisciplinary team approach. You all know the hypertension is the leading cause of kidney disease, notably the chronic kidney disease. About 1.28 billion adults worldwide have hypertension. Among them, 30 to 50% of patients having chronic kidney disease. And global CKD prevalence ranges from 10 to 13%. And hypertension prevalence in CKD is more than 80% of the patient. Among the hypertensive patients, more than 24 million people globally have chronic kidney disease, and they have a increasing incidence around 1.2 million per year. About 10.85 million people with CKD and hypertension receiving dialysis each year. Nearly 4.5 lakhs death occurs annually due to this chronic kidney disease and hypertension. And the trends of the global CKD due to hypertension is gradually and sharply increasing. And these increased trends is more importantly in our Southeast Asia. Important one is East Asia, and this risk is very high in this region. Uncontrolled blood pressure accelerates the renal and the cardiovascular dysfunction. That is why this topic is again very important clinically. As the blood pressure remains uncontrolled, it will speed the CKD progression. Cardiovascular morbidity and mortality rise in parallel with the abrupt rise of the CKD. So, dialysis initiation risk increases as blood pressure remains uncontrolled. Proteinuria is a very strong predictor for progression of the chronic kidney disease as well as an independent risk factor for the cardiovascular comorbidities. Each rise of 10 millimeter of systolic blood pressure is linked to 6 to 8% higher CKD progression rates. So it is very important to lower down the blood pressure even in a minute number. The hypertension and CKD relies on a bidirectional relationship, as hypertension can lead to development of CKD. Again, in patient with CKD, blood pressure may be raised. So these are very interrelated, and usually they adopt a abnormal pathophysiological mechanism involving hemodynamics alterations, neurohormonal abnormalities, different vascular changes. Among the hemodynamic abnormalities, the glomerular hyperfiltration, arteriolar hyaluronesis, tubulointerstitial injury are the leading mechanism, and these causes the renal injury leading to abnormal sodium handling and body fluid abnormalities, and this occurs due to sodium chloride co-transporter activation and impaired natriuresis and volume expansion due to salt and water retention. So, the pathology where hypertension exists to the glomerular injury and leads to proteinuria. Both hypertension and the proteinuria are co-founded risk factor for the cardiovascular risk. Also, it involves the neurohormonal activation, resulting sympathetic nervous system overactivity, renin, angiotensin, aldosterone system overactivation, and endothelium dysfunction. And very important one recently added as the mineralocorticoid receptor hypersignaling. All these leads and uh, leads to increased risk of different organ involvement, notably the kidney. It also causes some vascular changes resulting from inflammation, and it includes arterial stiffness and remodeling, vascular calcification, endothelial dysfunction, and capillary rarefaction. Once a patient having chronic kidney disease, they are categorized according on the basis of glomerular filtration rate, and the CKD stages varies ranges from grade 1 or step 1 to stage 5, and it the stages accelerates with the reduction of glomerular filtration rate. When the stages advanced, the risk usually become high, from low to moderate to high or very high. Along with this, the proteinuria is another category, and the albuminuria is categorized with the albumin creatinine ratio, and albuminuria 1 grade usually defined as the ACR level less than 30 milligram per gram. Albuminuria category 2 is defined as ACR ranging from 30 to 300 milligram per gram, and albuminuria 3 grade ranges when the proteinuria goes more than 300 milligram per gram. And with the advancement of this albuminuria, the risk also increased sharply. So both the hypertension, the albuminuria or the proteinuria, and the advancement of CKD confounded multiple comorbidities and morbidities. So we have to know whether a patient is having hypertension or not. So we have to get it very right. And blood pressure measurement, usually we should follow a standard protocol like office blood pressure measurement. But sometimes we may need blood pressure measurement at home or even with ambulatory blood pressure measurement. Different guidelines already exist to define the target blood pressure in different stages of CKD. Among them, the important are the KDIGO 2021, American Heart Association or American College of Cardiology, European Society of Cardiology or European Society of Heart Hypertension, and KEDUKI 20220. They have set the systolic blood pressure less than 120 to 30, and this range is acceptable blood pressure for all stages of CKD. But this these target blood pressure may not be even achievable in certain special conditions, especially in case of advanced CKD or with cardiovascular comorbidities. So then we have to individualize this target blood pressure so that our patient will not be in risk. To achieve this target blood pressure, we have to apply different modalities. Among them, the non-pharmacological intervention are very important, and it includes the sodium restriction, weight measurement, physical activities, alcohol reduction, sleep optimization, and smoking cessation. So these are very modifiable factors that will reduce the blood pressure significantly. And the other pharmacologic approaches include renin-angiotensin-aldosterone system blockade with AC inhibitor or ARB. And these are the primary drugs to address the CKD patient, especially when with proteinuria. So a patient with CKD and proteinuria with hypertension, first line antihypertensive drug will be a AC inhibitor or a ARB. But these two drugs will not be combined together to avoid the adverse side effect. The next drug is the HGL2 inhibitors, and these are the newer drugs very much effective for the CKD patient with heart failure. And a newer introduction is the phenyrenon, a non-steroidal mineralocorticoid receptor antagonist, is now indicated for CKD patient with type 2 diabetes mellitus. That is, diabetic kidney disease patient are in this group. Another very important antihypertensive drug is the diuretics. Different types of diuretics we are using, and before initiating a diuretics, we have to assess the EGFR status and the volume status. Also, we have to find out the abnormal complication or side effects like hypokalemia or hyponatremia or the volume depletion. Always we have to maintain the dry body weight. The albuminuria is the independent risk factor for both cardiovascular risk as well as the CKD risk. So we have to address the albuminuria, and our utmost effort will be to keep the albuminuria at the lowermost level. Hypertension is another complication after a patient having kidney transplant. There are many mechanisms, including the CNI vasoconstriction, sodium retention, and sympathetic activation or endothelial dysfunction are the important. And among these group, calcium channel blocker drug is the first choice of antihypertensive. So to address as well as to achieve the targeted blood pressure, we are in need of a multidisciplinary approach in a very integrated care pathway. And this integrated care pathway will screen and stage the different types of CKD patient, and their blood pressure will be recorded very accordingly, and blood pressure target will be set. Then we have to initiate the therapy and monitor the outcome and long-term follow-up. So, from our today's discussion, we have two different core takeaways. Standardize the blood pressure measurement. Initial treatment will be with RS blockade, and then to SGLT2 integration and volume management. And we have to stratify and address the risk factor like diabetes, and in these cases, phenyrenon is the drug of choice, and resistant hypertension to be addressed and diagnosed accurately. And we are in need of a multidisciplinary and integrated care pathway to have a better outcome. So I like everyone having the best future. So thank you all.